bypass surgery was the preferred treatment for coronary artery blockages. And to start with, when we started comparing angioplasty and bypass surgery, the negative aspects of angioplasty were reblockage rates and repeat interventions in these patients. And that is why we said that bypass surgery was better than angioplasty at that time when we did not have drug-eluting stents. So this is how, and these are the features which were more in favor of bypass graft surgery in patients having coronary artery blockages. So when the drug-eluting stents came in, the chance of restenosis decreased, the chance of repeat revascularization or repeat angioplasty or bypass surgery also decreased. However, bypass surgery also started improving at the same time with off-pump techniques and having less invasive approaches, and of course more experience and less recovery time with bypass surgery. But certainly at this time we can say that this balance is now absolutely horizontal, and that is why many such patients are saying no to bypass surgery because of the rapid and very effective use of interventional cardiology. So this is what we call as evolution of angioplasty, because earlier there were failure rates with angioplasty which has declined to a large extent, and now we don't need an emergency bypass surgery standby which was earlier there. Whenever we did angioplasty, we used to have a OT ready so that in case there is a problem, the patient is shifted to the bypass surgery for emergency surgery. So that problem has declined very rapidly. Emergency bypass surgeries are no more required. And then of course the reblockages rate or the restenosis has declined to a large extent, and stent thrombosis, which means sudden blockage of the stents, also has been controlled by the use of antiplatelet therapy. And that is why we say that the current results of DES are quite good and effective. And this is what the evolution has occurred in the field of interventional cardiology by use of drug-eluting stents. So drug-eluting stent, as I already told you, it is basically a stent with a drug coated on this. And now with the use of drug-eluting stents, we have also started doing multi-vessel angioplasty. Like if there are multiple blockages, still they can be treated by drug-eluting stent implantation. The fear about restenosis has decreased to a large extent, and in elderly patients, in high-risk patients, we can now avoid bypass surgery by use of drug-eluting stents. So the technology is still expanding and exploding, and as you will see, this is now absorbable stents. The stent will be there, it will remain there for about 6 months or about 8 months time, and then the stent will dissolve inside. And that is what the technology is going to, and these are known as bioabsorbable stents, which are now almost on the horizon, and maybe in the next few months we'll be doing these stent implantations. Many companies have started making this, and these stents will dissolve completely once, and the patients will not require antiplatelet therapy for a long period of time. So this is the promise which we have at this time, and maybe very soon this will be used for our patients. We also use various other technologies to improve stent implantation, and one of them is the use of intravascular ultrasound. This is a very fine catheter which we use. So this picture I will show you. Okay, so this is a picture of an intravascular ultrasound. There is a very micro catheter. It's taken inside the artery. This is the artery which is being treated by stent implantation, and this is the cross section of the artery which is taken through the intravascular ultrasound probe, which we are doing for many years now, and it is very effective in leading to effective stent implantation. So we know exactly that the stent has been implanted very successfully, and this has improved the results of stent implantation. So we have technologies to improve these results. And so many studies were done whether to show whether intravascular ultrasound implantation helps get better results with stent implantation. It was shown that yes, it is an effective tool, and it should be used especially in complicated cases or complex lesions. Many times we are not successful with just stent implantation, and we use these whenever we have long blockages, very calcified hard blockages, as in this patient. This is the but it is a rotational device which moves at the speed of 160,000 RPM, and you can see that this is being drilled inside, and this is coated with diamond chips. And once the drilling is done, then we do the stent implantation. So these are the cases which were earlier not possible to be done. We do by rotational atherectomy and stent implantation. So the technology is really helping us to do all kind of complicated cases these days. Then in field of myocardial infarction, as I must tell you, interventional cardiology has come in a big way, and this is the result of the studies which were done to compare stent implantation during acute MI and thrombolytic therapy. And it was shown that those patients who come with acute myocardial infarction, if you do angioplasty in the first 4 hours, it is very effective. It saves the heart, it saves the patients, and it is better than giving them streptokinase or any kind of thrombolytic therapy. And it has been proven in many randomized trials. So the accepted therapy these days is to do primary angioplasty or acute MI angioplasty as soon as possible within the first 4 hours, and it is better than thrombolytic therapy in these kind of patients. And these are various other new devices which are being used to save those patients who are very sick during acute heart attack or acute myocardial infarction, where we cool these patients or give aqueous oxygen during the coronary angioplasty to save those very sick patients, and in patients who are having cardiogenic shock. So in cardiogenic shock, the most effective therapy is to take them to the angiography and urgent angioplasty as soon as possible. So these were the trials which were done, and intra-aortic balloon pump is one of those devices which is very helpful. Whenever we have a patient whose BP is going down, he is developing cardiogenic shock, we put them on intra-aortic balloon pump immediately, start them on all kind of inotropes, etc. And it has been shown that in these registries, as you can see, that whenever you use thrombolytic therapy and intra-aortic balloon pump in sick patients, it is more effective than thrombolytic therapy alone. So this is a device which has been very helpful, and various other new devices which we are using, and one of them is a Impella device. The name of this device is Impella. It is a pump which we take inside the heart, and it starts working like a micro heart-lung bypass system, and which we have used in many patients now. And this is one of those patients, 81-year-old male patient who is a diabetic, who is having a myocardial infarction, very sick, hypotensive, had a cardiorespiratory arrest, was put on a balloon pump, and his heart ejection fraction or heart's pumping capacity is only 25%. And he was immediately shifted to the cath lab. You can imagine that nobody would take up these patients many years back. But now we take up these patients. This is a patient who was taken to the cath lab, very bad disease. And normally this disease would be treated only by bypass surgery. But now the technology has started helping us, and this is the Impella system, which is inside the left ventricle, and it is sucking up blood from the left ventricle and ejecting inside the aorta. And that is how it works, like a mini heart bypass system. And then once that is functioning, the angioplasty is done simultaneously. And as you can see, the angioplasty, and this is a catheter through which angioplasty is being done. And this is the way it goes inside. This is the Impella system, which again goes through one of the femoral arteries from the opposite side and goes inside the heart. And this catheter, which sucks out blood from the left ventricle, because left ventricle is failing, it is not able to eject blood inside the circulatory system. So it sucks from here. This is the rotor system which is moving, and then ejects inside the aorta. And this is the way it helps the heart to sustain that angioplasty or that severe state of shock